I'm Nathalie van Havre. I'm the Head of Education at the European Hematology Association.
My name is Hartmut Döhner. I'm a professor of medicine and hematologist-oncologist located at Ulm University Hospital in Ulm, Germany.
And we're here to discuss a paper published in Blood called Genomic Profiling for Clinical Decision-Making in Myeloid Neoplasms and Acute Leukemia. Hartmut, I have a few questions for you. Can you explain to us what is the role of genomic characterization specifically in myeloid neoplasms?
Well, genomic characterization of leukemias has become integral part of the initial workup of an AML, both to establish the correct diagnosis, to identify important prognostic factors, and of course to also identify potential targets for the evolving field of precision medicines that we now have available.
And which are the main methods of genomic testing that are used today to detect genetic abnormalities in myeloid disorders?
Yeah, I would say in routine clinical diagnostics, the main techniques it's still conventional cytogenetics, which is integral part of the initial workup. It usually takes time. I mean, in the paper we say that results should be available within 5 to 7 days, knowing of course that in many, if not most institutions, that is not realistic. So usually centers will receive the results from cytogenetics within maybe 3 to 4 weeks. And then all the entire spectrum of molecular techniques, still conventional PCR technique, but more and more the NGS-based technology, so the next generation sequencing-based assays have become more and more important. And then to mention another technique, that is quantitative PCR for monitoring measurable residual disease. Also very active field of research, not only research, but also important now for clinical decision making. So I think these are the main techniques that we're currently using.
Mm-hmm. And what kind of relevant information do these tests actually provide? I'm thinking somatic mutations, I'm thinking germline mutations, but why are these important?
Yeah, as I mentioned, I mean, first of all, we need to establish the correct diagnosis. So, as you may know, we in parallel to the paper you mentioned, we have published the new international consensus classification of AML that reflects all the new knowledge now we have on the diseases, on myeloid disease like myelodysplastic syndrome or acute myeloid leukemia. And if you see this new classification, more and more genetic markers are reflected in this classification. So more and more diseases are diagnosed based on the presence of specific mutations. So this is a paradigm shift from 20 years ago, where leukemias were basically diagnosed based on morphology, so on light microscopy. So that is a major paradigm shift in establishing the diagnosis. The second important issue is the identification of prognostic factors, not necessarily related to diagnostic markers. And the third important aspect is the rapid diagnosis of therapeutic targets, and here in particular the activating FLT3 mutations and mutations in the IDH1 and IDH2 genes. There are other genes that are becoming more and more important in selecting therapy or selecting patients for clinical trials, such as the rapid detection of TP53 mutations.
Mm-hmm. So you've pretty much answered my next question, because I was going to ask you whether the genomic tests were relevant in terms of for the current classification, or whether morphology was still the main thing we relied upon for the diagnostic evaluation of myeloid neoplasms?
I mean, we have gone through the 30 years ago through the so-called FAB, French, American, British classification that was purely based on morphology, which was great. And then, the WHO classification that came in the late 90s that for the first time incorporated genetic markers. And we have seen an increasing proportion of genetic markers being increased in this disease classification, now culminating in this new ICC, the International Consensus Classification, where the vast majority of AML cases are now diagnosed based on specific genetic markers.
So you make it very clear how important it is to be able to study these genetic markers. How should a hematology clinical lab be equipped nowadays for genomic workup, and what are the essential techniques that a lab should be able to use?
Yeah, I think we already talked about the essential techniques. That's basically, it's cytogenetics and the portfolio of molecular techniques. Often these two techniques, types of techniques are being done in separate laboratories, actually. So cytogenetics in a cytogenetics laboratory. I mean, for a single institution, it is becoming more and more difficult to establish all these diagnostics. I mean, a smaller community hospital, city hospital, will not be able to establish these techniques. So it will be, I think, more and more centralized in highly specialized university hospitals, or even in commercial labs that of course can be highly specialized. So I think the diagnostics cannot be performed in every hospital. That's for sure.
But I assume it's very important for all general hematologists to be aware of the need for these techniques, because that will determine the diagnostic and then the treatment, especially in the context of precision hematology.
Absolutely, but another problem is, of course, again, in less well-resourced countries, not everybody has access to these techniques. So there are many countries where these NGS-based technologies are still not available, and this is a problem. Yeah? So these centers, these physicians will not be able to to classify the AML according to the newest classification. Yeah. So that's a drawback.
Yeah, it is definitely a problem even within Europe.
Even within Europe, you have quite some heterogeneity. And another issue, of course, is with these complicated techniques, a big problem is harmonization or even standardization of these techniques, which is a big issue. Yeah.
Once you identify a genomic variant, how can it be quantified, and how relevant is it to quantify this variant?
Yeah, I mean, the quantification is currently not the most important factor. So it's basically it's the fact, can you identify the genetic marker or not? It's becoming very important. I briefly mentioned the technique of measuring measurable residual disease, so the MRD, where you quantify actually specific genetic markers. So in this context, it has become very important to quantify. But at the time of diagnosis, currently, it is not really reflected in terms of, decision making or clinical care.
Okay, and one more question about variants, but this time about germline variants. How significant are they, and in which patient is there a need for investigation of these germline variants?
Yeah, again, that's a very important emerging field. A few years ago, we thought, it's not actually occurring in adult patients, but now we know that an increasing proportion of patients actually have myeloid disease with a germline predisposition mutation. So there are specific mutations where we know it's quite frequent, like the RUNX1 mutation or the CEP alpha mutation. It's much more frequent in children, of course. But there's another mutation which was identified a few years ago. It's the DDX41 mutation that typically actually occurs in older patients. So median age of 65 or even higher, where these germline mutations occur. So it's not a phenomenon that is restricted to children or young adults, but can also be seen in older patients. I mean, once you identify a germline variant, I think it needs to be discussed with the patient and the family. If the patient or the family would like to have a consultation with a human geneticist to analyze family members, that's important. And another important factor relates to the identification of a stem cell donor in case an allogeneic transplant is recommended for the patient. Mm-hmm. So then if you consider taking a sibling of the patient, then of course the sibling needs to be analyzed whether the germline mutation is present in a sibling or not. So this has become very, very important.
How do you differentiate a germline variant from somatic mutations?
Yeah, I think that's an important issue. Which tissue you use? The best way is still to perform a skin biopsy and to analyze skin fibroblasts to be sure that you don't use a tissue that is contaminated by blood. So that's an important point. Yeah.
And just to finish, which challenges do you envision in the implementation of comprehensive genomic assessment in more or less routine clinical practice in your field?
Yeah, I already mentioned harmonization and standardization of the techniques. Of course, it's a rapidly evolving field in terms of technology. So the technology will evolve. There will be new technologies being applied in the clinic. It's the cost, yeah, which is an issue. And another issue we discussed already is the broad availability of these tests. If we think globally, across all countries. So there are major challenges, but a few years ago, next generation sequencing were much more complicated than nowadays. The first tumor genome was identified in 2008. It was actually an AML genome. 5 years later, we had this seminal paper by the Cancer Genome Atlas Project, analyzing 200 or even more patients. So this is only about 10 years ago, and now we are routinely applying these techniques in clinical diagnosis. So it's an enormous development we have seen over the last years.
Well, thank you very much, Hartmut. That was very informative discussion.
My pleasure. Thank you.